Okay, my clock is showing 2 o'clock Eastern, so we're going to get started. Welcome everyone to today's webinar on updated Medicaid transportation guidance and what it means for transit agencies and state DOTs. My name is Liz Taylor. I'm the Assistant Director at National RTAP. We also have Robin Phillips, our Executive Director. And we're very pleased to have Robbie Sarles of RLS & Associates presenting today. She has a lot to cover. In fact, it would take us a whole day to cover all the questions that we received in registration. So I'm going to try to be quick with some introductory comments and turn it over to her. So a couple of housekeeping items. The recording and slides will be posted on our website, nationalrtap.org/webinars within 1 week. Please enter your questions into the Q&A box in the Zoom control panel, and we'll address them at the end. If you're having any trouble with Zoom, please send us a chat, or you can email info@nationalrtap.org and we'll try to help you. You will have a very brief, just a few questions survey that will pop up in your browser at the end of the webinar. So please take a few minutes to fill that out. It helps us inform future webinars and events. And as I mentioned, we got a lot of response to this webinar and a lot of really great questions. So we're going to work on putting together either additional webinars or workshops and working with partners on this. So please let us know what your training needs are. So for those not familiar with us, we are the National Rural Transit Assistance Program, or National RTAP. And we are a technical assistance center funded through the FTA Section 5311 formula program for rural areas. We provide training and technical assistance to rural and tribal public transit operators and to state programs, state RTAPs. We're guided by a review board with those target audiences, and you can learn more about us and access all of our resources on our website. The homepage is shown here. It's nationalrtap.org. And we can categorize our products and services, all that are of no cost, into these 5 categories: training, information, technology tools, peer networking, and assistance. And we love hearing from you. So please let us know if there are questions you have, if you're having trouble finding something. If we don't have it, we can connect you to someone who can answer your question or has a resource. We really try to be a hub of information on rural and tribal transit. And like I said, we love hearing from you. So please be in touch. So now I'm very pleased to present Robbie Sarles, who's presenting today on this important topic that she is an expert in. So she is the president and founder of RLS & Associates, a transit consulting firm headquartered in Dayton, Ohio, with 40 staff and offices in 8 other states. For over 40 years, she's provided transit planning and operating assistance to urban and rural transit systems, state departments of transportation, and local governments across the country. Ms. Sarles is a nationally recognized researcher, trainer, and presenter on a variety of topics, including regulatory compliance, safety, human service agency coordination, mobility management, and non-emergency medical transportation. She holds a master's degree in both civil engineering and city and regional planning from The Ohio State University and a Bachelor of Science from Western Kentucky University. So we're now going to switch screens and turn it over to Robbie.
Okay. Well, let's see. Hopefully everybody can see my screen.
Not yet.
Not yet. Well, then let's try that again. Oh, my goodness. We'll try.
I was just informed that my slides were not advancing, so you will be able to see a PDF of them after the fact. All right, these are the more important slides. So Robbie, take it away. We can see your screen.
There we go. There. Can you see it full screen now?
Yes.
Good. Thank you. Well, good afternoon, everybody. And thank you, Liz and Robin, for the invitation to present on this topic that is been met with a lot of questions, a lot of enthusiasm, and I think it's just people are very anxious to hear about this I think we have well over 600 folks in attendance today. So, we'll attempt to get through the presentation and still allow some time for questions at the end. Whether we'll be able to get through all of them, probably not. But as Liz said, we realize as an industry that we need to perhaps provide a lot more information in the future. So thank you for attending the session, and communicate what your needs are so that we can continue to make progress towards that in the future. So one of the questions is why is everybody so interested in this? I mean, as a public transportation industry, we've been working in this NEMT world, or trying to, for decades. And I think that the operative word in that sentence I just said was, we've been trying to operate in that environment. I think that over the last 30 years, the industry has had lots of questions, perhaps some confusion, historically perhaps some frustration, and because oftentimes it's been very difficult to get answers and to really understand what NEMT really is, and how public transportation can really partner. And sometimes it seemed as if we were from two different universes. Sometimes we're using the same language, but it didn't seem like we were actually talking about many of the same things. And when you look back at some of the guidance that has been provided historically, it really has been 3 decades. It's been almost 30 years since CMS had really produced any really well direction, and oftentimes it were in Dear Colleague letters to state Medicaid directors, as opposed to correspondence or any type of guidance that was available to everyone. So I think that given that, that's one of the reasons why this new guidance, people were so interested in it. It's because for the first time in years, we're actually getting some clear guidance from what it is that the Center for Medicare and Medicaid Services, what it is the views are really regarding non-emergency medical transportation. And before I get really in too far here started, I really want to say that this is really exciting. It may not have gone as far as we in the transit industry perhaps would have liked for it to have gone, but I think that what this guidance represents is a real change in CMS and their respect and acknowledgement of public transportation, and just the fact that public transportation really is a viable means of providing non-emergency medical transportation. And it really does break with perhaps some historical concerns that had been expressed previously by CMS about that. So I think we have a new day, a new age here, and this guidance really does reflect significant improvements in the relationship between public transportation, particularly FTA, and CMS. And I think that goes back to a lot of what CCAM and the Coordinating Council on Access and Mobility has been able to really create. I think it demonstrates that CMS is listening. When you really read and look at some of the nuances of this guidance, you're going to see that public transportation and our concerns are addressed throughout the document. I think it also indicates that CMS is not particularly satisfied with perhaps the way NEMT has been provided always in the past, and that there are some real challenges that this guidance creates for the state Medicaid directors and the whole transportation industry as a whole. I think it sends a very positive message about the future and about possible partnerships. I think it also, one of the things that it does is it discusses and provides flexibility it gives flexibility to the way state Medicaid directors can handle NEMT. And in many ways, it takes away what perhaps has historically been some obstacles to coordination with public transportation services. In other words, previously, a lot of times because perhaps CMS had not vocalized or had not provided guidance on specific issues, people interpreted that as being that the answer was no. And I think what this guidance has done is removed a lot of those things, because it's basically said the answer is not no. The answer is we encourage you to be flexible. So I think that's a very positive thing. One other really great thing that came out about this guidance is that oftentimes CMS, when we as the public transit industry would look at it, it would almost seem as if CMS was working in its own universe and perhaps really didn't realize that there was, this greater transportation network out there. Oftentimes they were very, very focused just on what they did and really didn't understand nor know what else was going on in the rest of the transportation universe. But that, I think, was signaled that there was a change there as well in this guidance, in that it does very clearly indicate that CMS and NEMT services are one part of a larger transportation network that is out there, and it does recognize that. So there are about 4 or 5, maybe 6 major takeaways that I think when we go over the specifics of this guidance, I think if you look at it, you're going to see some of those themes that I've spoken of are going to ring true as we go through the discussion of each of these major points. So with that, I think one of the things that we've learned over the years is that oftentimes public transportation folks don't necessarily understand NEMT or the Medicaid folks, and vice versa. And so one of the things that I just want to do is indicate that this guidance really does clearly state a number of things that I think that we as public transit folks can really learn a lot from and really understand. And the first thing is really understanding where transportation falls in the overall realm of Medicaid. And so I think it's critical that you understand these things, especially when you're having dialogue with your either brokers or your state Medicaid agencies or directors, that you understand some of these things, understand some of this language, because it'll help you as you have those, as you try to further that dialogue within your communities. The very first thing that is critical is to understand that transportation is considered an essential feature of the Medicaid program. It is an essential feature. That means that every beneficiary of Medicaid service needs to have access to health care. And that drives pretty much everything that Medicaid does when it comes to how the non-emergency medical transportation service is provided. We're going to talk just about NEMT. We do need to understand that Medicaid is extremely complicated, and the Medicaid transportation program is very complicated. And so for purposes of this discussion, we're going to focus in and only really talk about NEMT services and what that means for public transportation. Also, we need to understand that unlike FTA, where FTA directs and provides oversight and monitors and funds us all, we look to FTA, and when FTA says to do something, well, we comply. One of the things that is different is that CMS does not have that same role. CMS provides guidance and the overall infrastructure that needs to be followed, but essentially state Medicaid directors have a significant amount of leeway and autonomy on how they administer their programs within their state. So when we talk about this guidance, it's important to know that it is guidance. It is not a requirement. It is not a regulation. It is guidance to those individual state Medicaid directors. Each of those directors can choose to follow this guidance, and they can also choose not to follow this guidance. So I think that that's important to know. So we have 50 different states and 50 different approaches to Medicaid and to non-emergency medical transportation. That is one of the reasons why it's sometimes difficult for us to understand, and for us to understand that what is happening in one place is not necessarily what is going to happen in another state or another place. What happens is those state Medicaid directors actually and with their agencies create state plans. And in that state plan, it has to describe the method that's used to ensure that transportation services are provided, or that transportation assurance is in fact actually followed. So the first step is, if you want to know what is happening in your state regarding Medicaid and NEMT, you really need to understand that you need to go and find that state plan or work with your local folks to understand what is the approach that your state is using. But to understand that there is the statutory requirement, a requirement to provide transportation and to provide access to all beneficiaries to access healthcare. Okay. Also, a few years back, there was an act that basically obligated CMS to do 3 different things. The first thing that it required CMS to do was to convene a series of meetings to obtain feedback and facilitate discussion. That occurred late in 2023, in the fall, in that September timeframe. And so they did actually convene the series of meetings. They were listening sessions, and many of you probably participated in those. The purpose of that was to hear what's happening with NEMT, what's happening, what's working well, what's not working well. And then that feedback actually was used to accomplish the second thing, which was to assess and update the CMS guidance that had been issued previously, and to consolidate it, to update it, and to make it hopefully make sense, and then to communicate it. That's what the guidance that we're talking about today, this was the outcome of that effort. And so they've completed the first step, they've completed the second step. The third step is that they then are also to report back to Congress on NEMT based on an analysis of nationwide data. This is not complete yet, and part of the reason why is because there's no real good source of nationwide data. And so they have yet to actually complete that. But we are here to talk about the second bullet on this slide. Okay. So as I said before, CMS just provides guidance. They provided this guidance to state Medicaid directors they provided a letter announcement and then attached the guidance to it. That was published in September 28th of 2023. And essentially what it did was it provided an overview of the requirements, policy, and guidance for that transportation assurance in Medicaid as a mandatory service. One of the important things that it did was it called on those states, on those Medicaid directors, to fully operationalize, to monitor, and to improve the way that they meet the transportation assurance. You're going to notice on my slides here that that last statement is in blue. You're going to notice throughout the presentation that there are a number of sentences or bullet points that are in blue. Bear with me. That's my editorial comment about putting an exclamation point behind certain things. In other words, I wanted to emphasize certain points here so that all of you that are in attendance can say, wow, that's an important thing to make note of. And so I think that the point here that I made earlier was CMS is basically saying to the state Medicaid directors, we want you to perhaps improve the way that you're meeting that transportation assurance. We want you to monitor and improve it because we think we can do a better job. Okay. Again, the guidance was authored by the Centers for Medicare and Medicaid Services, also known as CMS. I want to point out that this was an absolute Herculean effort. This went, I'm not going to say went against decades, but definitely worked through and navigated through decades of non verbalization of these issues and many of these concerns. So being able to pull all of this decades of informal or formal guidance all into one place, attempting to make sense out of all of it, and then to put it in such a way that communicates well to Medicaid directors and then those of us as well. It was a massive effort. You know, again, like I said, a lot of people think that they'd like for this to have gone farther. They'd like for it to have been requirements. They'd like for it to have done all kinds of things. But I'm here to tell you that they made significant efforts and significant progress in putting this guidance together. It does reflect the Coordinating Council on Access and Mobility, CCAM. They've been working for years, primarily Danielle Nelson from FTA that's been working with CCAM. They've been working for years hand in hand to educate and inform each other, inform FTA about CMS and what their requirements are, but also importantly for us to educate and inform CMS on what FTA and what transit is all about. So if you guys know Danielle, thank her because she did a lot of work on this. Okay. What does it do? Again, a compilation of the Medicaid transportation policy on federal requirements. And you're going to see here, I put this in blue, state flexibilities. It clarified what the existing rules were. It clarified and explained what was new, and then it significantly encouraged best practices. I want to emphasize that. It encouraged best practices. CMS would love to see new and innovative ways of approaching NEMT services. It encourages states, managed care organizations, and transportation providers to work collaboratively to ensure that beneficiaries are educated and informed. Again, one of the concerns is a lot of this has been expressed repeatedly in our public transportation arena, is oftentimes beneficiaries, Medicaid beneficiaries, essentially just give up because they don't understand NEMT, they don't know how to get services, they don't know what they're entitled to. And so oftentimes NEMT services are really underutilized utilized because of that. And so CMS recognizes that. And they said, we need to work together to educate and inform our beneficiaries. Okay. Transportation access is for necessary transportation. CMS does not, Medicaid is not to be used for all transportation. It's only to be used when no other option is available. It is to be used, we're supposed to be using the nearest qualified provider unless there's a medical need. This third point is huge. The state Medicaid directors want to find the least costly, most appropriate means of providing NEMT services. Up to this point, and I think historically, many experts would agree that the focus has been on least costly, and that oftentimes the most appropriate part of that phrase has been outweighed by the focus on least costly. One could argue because it's the different models that are used within the different states that focused on cost. and because Medicaid is very, very concerned about cost. But one of the things that CMS did in this guidance was really focus on that term most appropriate. What they recognize is the least costly if that service is not provided by a quality service provider, if there are no shows by the service providers, if folks don't they can't depend on that pickup, if the drivers are not adequately trained, if the vehicles are not adequate, then even if it's least costly, it is not most appropriate. And so this guidance has recognized that most appropriate means you need to take into consideration the physical, emotional condition of the beneficiary, and you must consider the quality of service when you're making your selection of what service provider should be selected to provide a specific trip. This is huge for public transportation, because we are, in most cases, going to be the most appropriate service provider. And this is an area that I think that when you are communicating, in your local communities, negotiating with brokers, negotiating with, depending on what model is being used, your, managed care organizations, whatever your model is in your state, the first thing that you need to bring to the table is the fact that you may be the most appropriate. At a recent conference of managed care organizations, 2 or 3 of the largest MCOs, their executive directors actually spoke to the fact that public transportation can be considered the most appropriate because we already have the relationship with our service, with our passengers. They already trust us. We already have credibility with them. They know we're going to show up. They know we're reliable. And so the conclusion of these MCO executive directors was public transportation should absolutely be considered, maybe even as the first choice, because we are the most appropriate. So I think this is a key term that you'll want to make sure that you emphasize. Also, the requirements are to improve passenger provider relations. And, there's the concern about you have to have a good relationship with your service provider. Otherwise, passengers won't ride. This is a quote that I typically wouldn't do this, but I'm going to read it because this is huge. And this is a quote directly from the guidance. It says, "A negative transportation experience can have a direct impact on both the driver's willingness to accept a passenger and a beneficiary's willingness to accept a ride. To ensure transportation providers, such as drivers, have the necessary tools to engage beneficiaries and ensure a positive experience, CMS recognizes that there may be a need for additional steps to help manage the transportation provider beneficiary relationship." I think this is massive. It truly recognizes some of the failings of the NEMT services perhaps been provided in the past. And again, it also acknowledges that providers need to have perhaps additional resources and need to work cooperatively in order to make sure that the beneficiaries understand and to make sure that everybody has a very positive experience with the transportation. So I think this is very telling of where CMS is. Okay. It also says the state should address unique challenges. This has been around for a while, but again, one of the things that the guidance did has pulled it all together in one place. It recognizes that not all trips are equal. Not all beneficiaries' needs are equal. And so it does go into some detail about making sure that there are reasonable modifications for individuals with disabilities and that we can consider their support needs when we transport them. This is not new to public transportation. This is what we do on a day-to-day basis. Also, to consider behavioral health needs when determining most appropriate. It also acknowledges that tribal beneficiaries also might have unique needs specific with geographic barriers. And then the last point here, you're going to notice I put it in blue because I think we need about 3 exclamation marks behind this. They are suggesting that the states understand that there is a higher cost of doing business in rural areas than elsewhere, and that perhaps states need to consider providing flexibility to set higher base rates in those areas, and that they need to perhaps consider alternative rate methodologies. This is also, again, it doesn't require the states to do it, but it definitely encourages them to do it. And so when you are in the process of negotiating or working with the folks in your community, this last bullet point is fairly significant, and that you can take this to the negotiating table. When it comes to the alternative rate methodologies, we're going to talk more about that a little later, because again, the way that perhaps folks have been paid in the past perhaps has not been equitable nor fair. And so this provides some significant flexibilities to make sure that providers are adequately paid for the cost of the services that they're providing. CMS recognizes public transportation agencies as viable NEMT options. That just seems just so straightforward, and no one in the public transportation industry would have ever thought that perhaps that's a comment worth putting, an exclamation mark behind. But historically, CMS has not necessarily always perceived public transportation as a viable option, and so this represents a major philosophical change. And again, the statement throughout the guidance recognizes public transportation as a viable option. CMS also does recognize TNCs as an option, but that it also recognizes all of the significant challenges that would make that perhaps not as viable because of the ride and financial efficiencies and being most appropriate. So it does recognize that as a possibility, but it doesn't. But it really very much recognizes public transportation as a least costly and most appropriate option that should be considered. State Medicaid agencies are also encouraged to explore partnership with state DOT agencies to better serve the Medicaid population. This is also massive. There have been a lot of state initiatives over the last multiple decades where often DOTs are often the leads, where they bring state agencies together and try to figure out how we can provide better coordinated transportation, to do more with the limited resources that we have. We all want to work together to make sure that our the residents of our states have the necessary transportation. Oftentimes, Medicaid has never participated in those meetings, or never participated in a significant way. Well, we'll leave it at that. And so what CMS has recognized that state Medicaid agencies really should be perhaps a part of those efforts. And so even though they didn't require it, they did encourage it. And so this is, again, another opportunity for us to have dialogue, especially if they're state DOTs. We can always point to this part of the guidance and say, well, we hope that you will participate in these state initiatives. The National Center for Mobility Management is doing a number of roundtables trying to encourage these kinds of partnerships, and I think that they may be happening throughout the country. We certainly hope that they will, and that our state Medicaid directors will embrace this part of the guidance. It basically spelled out for public transit what we can, how NEMT and how public transportation in a fixed route environment can be utilized to provide Medicaid trips. It very specifically says that a Medicaid beneficiary can use public transportation like any other individual can, that they should not be charged a fare or a rate any more than what is charged to the general public. They should be provided the same fares, the same discounts, everything should be the same. And that's for the fixed route portion. They have also indicated that passes and tickets are also can also be utilized. They want to make sure that the cost of the pass or the ticket, however, is equal to or less than the cost of what that Medicaid beneficiary would pay if they were taking individual trips. So in other words, if the Medicaid beneficiary was going to take 4 fixed route trips, and let's say each of those trips cost $2, 4 times 2 is 8. But if they could get a weekly pass where those same trips could be performed, but that pass is only $5 because the pass is cheaper than what the individual fares would be, then the passes and the tickets absolutely, of course, can be used for that. But one of the big distinctions that has been made is once that pass or ticket or whatever has been purchased, if that beneficiary then also chooses to use that pass for other trips in addition to the Medicaid trips, they can do that. And even though that seems commonsensical as well, historically that has not always been the case and has not always been consistent with the direction that has been provided. So I think that this is great that it's very clearly spelled out in the guidance. How it is to be determined whether or not a pass or a ticket can be used, but also the acknowledgement that if in fact that individual uses that pass for other purposes, that's acceptable as well. If they use that pass to go to the pharmacy, if they use that pass to go to work, if they use that pass to go to the grocery store, that's accepted as well, as long as the base Medicaid trips are being provided. So that's like I said, seems commonsensical, but is really good that we've seen it very clearly written. Okay. There's also been some concern about ADA complementary paratransit service. We in the transit industry might be concerned and might use the term shedding, or where essentially the thought is that all of these Medicaid folks are going to come on and basically use up all the capacity that we have in our ADA complementary paratransit service. Well, I think the first thing we need to recognize is a Medicaid beneficiary, if they meet ADA eligibility requirements, they have the same access to the service as anyone would. However, if there is additional service that's being provided, you can essentially, the Medicaid entity that is purchasing those services, you can charge them at a rate higher than the fare, as long as that rate does not exceed the lowest rate that you would charge another entity that provides service under a contract. So let me give you an example. Let's say that you provide a contract to your local Center for the for Visually Impaired, and let's say that your fare is like $5, but under this contractual relationship you have with this other entity, and let's say you charge them the equivalent of $6 a ride. From an NEMT perspective, you can still charge that entity more than the fare, but you can't charge them more than the $6 fare. So whatever the lowest rate that you, your lowest contract rate that you provide, or that you would charge, another entity, that is the rate that you have to charge the NEMT services or the Medicaid services. So I think that it's pretty clear that they understand a little bit about what's going on with shedding, a little bit of understanding of what those concerns were. And essentially, I also put this statement in quotes here at the bottom of the slide, and this is their word. It says, the fiscal burden of transportation must not be unfairly placed on paratransit. And in this phrase, they really mean complementary paratransit. So it really depends on how the services are provided. If it's an individual, that's one thing, but if basically you're providing those services under a contract, then it would be the lowest contract fare that you could charge. Okay. And so that's complementary paratransit service. Under those of you who provide public demand responsive service, so those might be folks perhaps typically in more rural communities, but could be urban as well. But if there are public demand responsive services that are not complementary paratransit, that are not associated with fixed route, that are separate public demand responsive transportation services, those also would have the same provisions. In other words, whatever the lowest contract rate that you provide, for other entities, that's the rate you have to charge for the Medicaid trips. Okay, so no more than the rate charged to any other state human service agency for comparable service. I also want to point out the term comparable service, that's important, because you might provide a lot of contracts with a lot of different types of service. You need to make sure that you're measuring against comparable service. Okay. This is a biggie. A lot of people have thought that CMS has historically precluded or not allowed trip sharing. CMS has made it very clear. Trip sharing is allowed. So if you can have a vehicle that's got, somebody going to aging, somebody going to a meal site, you can have, and as well as you can have NEMT folks on that same vehicle, you can share trips. That is significant. There are caveats, obviously. The first one is that Medicaid is the payer of last resort. So if a person's eligible for multiple funding sources, Medicaid is the payer of last resort. And Medicaid only pays for its portion of the coordinated trip. Okay, they don't want to cross-subsidize these other entities, just like these other entities don't want to cross-subsidize Medicaid either. So states have the flexibility to utilize cost allocation methods reflecting basic cost principles. This is really significant, okay? States have flexibility to utilize cost allocation methods that reflect basic cost principles. Even though it didn't specifically refer to the CCAM efforts that have been made up to date, it definitely includes them by implied reference. And so what you need to know is that CCAM has been working with FTA and CMS through CCAM have been working for a number of years to come up with basic cost principles that that both parties can agree to. And that they then have agreed to essentially the basic parameters of what is being called the SBIR cost allocation model. You guys may have heard of that. if we have time, I'm gonna get to that, show a few slides on that at the end of the presentation. But essentially it is a model that was put together with the participation of CMS that basically meets CMS's requirements regarding cost allocation, and that this is one method. They're not telling states that they have to use this method, but there is at least one method that is going to be available that meets this need for appropriate cost allocation. So I'll talk more about that in a bit. But I think that this is massive. in that it allows that flexibility, where before states always, or a lot of times state Medicaid directors have said, no, we can't do that. No, we can't do that. CMS is not only saying, yes, you can do it, they're absolutely encouraging it. Okay. This is also, I think, really massive. They're saying whenever the state Medicaid directors, and this then funnels down to brokers, MCOs, to, everybody, that when you're dealing with provider payments, and when we're talking about providers, we're talking public transit, it could be private for-profit, it could be nonprofit entities, but any provider, that they must not offer payment too low so that it results in a limited number of potential service providers. In other words, some of you may be in states where the state comes in and says, we'll pay you $12.50 a trip, period. Well, the reality may be that trips can't be provided at that cost. In fact, it's probably unlikely that trips can be provided at that cost. But in doing so, then they have, by that very nature, limited the number of individuals, number of providers that would be willing to provide those services. And so this very clearly says, when you're coming up with your provider payment process, it cannot be so low that it impacts the number of potential service providers. This is also a great negotiation tool when you are there talking with your folks. Come back to this statement, because it very clearly is indicating that what's happened in the past perhaps has not been well received by CMS. In other words, when we are basically underpaying service providers, the end result is we have fewer service providers. We may not have the quality of service providers. We may have all kinds of issues that go along with that. And so CMS is saying, okay, guys, you need to be paying for, you need to be paying what the cost of service is. States also have the flexibility to explore a broad array of innovative payment models. So they've got a lot of flexibility here. Okay. This is also a pretty significant point, in that CMS has always said, no, we're not going to pay for no-shows. No, we're not going to pay for deadhead miles. But they have realized, I think, and it has a lot to do with the activities that have occurred through CCAM and through Danielle Nelson's efforts, that they are, and through developing that cost allocation model that we've talked about, folks have become very aware that deadhead miles and no-shows and all those other things are really expensive, and that they are true costs. And so even though those cannot be paid as a direct activity, CMS is acknowledging that they can be built into a payment methodology. I want to just let that sink in for a while, because that's pretty significant. Where before people would say, oh no, we can't pay for this and this and this. Now what they're saying is, service providers, you can include it in your negotiated rates, and that's acceptable. And again, obviously each state Medicaid director has to be, open to that, but it is very clearly saying that those can be included as indirect costs, and including, long wait times, all of these things. This is another quote that I think is pretty darn significant. These may result in significant costs. So when it said these, it's referring to the no-show, the deadhead, and the wait times. These may result in significant costs to transportation providers, and failure to account for them would negatively affect providers' willingness to transport Medicaid beneficiaries. That's a statement you can take to the negotiation table. Okay. Provider payments are also, and these have always been the case, but again, they're all in this guidance. They're spelled out clearly in the guidance. Travel-related costs that can be covered as a direct expense if there are overnight long distance trips, lodging, meals, or if there's a transportation attendant. And then it also says that states are afforded flexibility for coverage of wait times and long distance trips. The guidance goes in to talk about broker requirements. This is not new. It just puts it all in one place. But what it does do is clearly tell the Medicaid directors, again, very clearly states that the expectation is that they have to provide robust oversight of the brokers. That it means monitoring complaints, doing audits, making sure that driver standards are being met, vehicle standards are being met, that beneficiaries truly do have access to transportation, and that might even mean providing scheduling assistance. So it's not a hands-off arrangement. If you've got a broker, it doesn't mean that state Medicaid directors no longer have to be concerned about these things. This guidance very clearly says you have to provide oversight of your brokers, and you're accountable for what your brokers do. Brokers do have to go through a competitive bidding process. There's nothing that's changed about that. They're also prohibited from having conflicts of interest. So brokers cannot provide trips directly. They cannot have any subcontract with any entity that they have a financial interest in, unless certain exceptions are met, and those are very hard to come by. Public brokers, there aren't many of them, but they're also permitted, and this clearly spells out that public brokers also have to go through a competitive bid process, but they are exempt from some of the conflict of interest issues if they directly provide service or if they're subcontracting to another governmental provider. So that does allow some self-referral. They have to make sure that the payment does not exceed the actual cost of the service, and that we want to make sure that separate cost centers would be provided. So the cost of the brokerage is in fact truly separate from the other operations, the other entities, parts of the entity's operations. And again, has to be the most appropriate, lowest cost. Another thing that has came out of the CCAM work that FT has been doing with CMS is historically CMS folks have not understood, apparently not understood the relationship that public transportation and non-emergency medical transportation has, and that many of you use and depend on that NEMT service to serve as your local match. That concept was foreign to CMS because they did not, they can't match, they can't use any other monies to match theirs. So they didn't understand, at least it seems as if there was some confusion very early on. And so there's been a lot of work at the CCAM level to make sure that everybody, including CMS, recognize that fundraising is permitted. Again, you can't match Medicaid, but you can use Medicaid dollars to match transit, particularly the 5311, 5310, and 5307 programs. This very clearly spelled that out. That's pretty much an overview of the guidance. I tried to, where possible, indicate where I think that there are some real significant opportunities there for all of us in the public transportation industry. But before I open questions, I'd like to spend just a few minutes going over the NEMT cost allocation model that has been put together with the input, through CCAM with the input of CMS. Because as you are, whether you choose to use this model in the future, or whether you use any other model or work with your states to come up with other cost allocation models, I think the basic premises that are spelled out here can be very valuable to you, particularly in as you're working through some of those things and through that negotiation. So this particular model, first of all, I want to make sure that it actually is in the FAST Act. Congress has, at least there's a part of Congress that has been very concerned about NEMT for a number of years, and has been very concerned about coordination of services for decades. And actually, the FAST Act actually stipulated that the DOT and CCAM and all the CCAM partners needed to work together to develop a cost allocation technology that would account for the different federal reporting requirements and that would maintain a separation of funding sources by trip for NEMT. In other words, they want to make sure that, yes, you can share trips, but that no agency is going to subsidize another agency. Every agency just pays their fair share of the cost of that trip. And so that was essentially what was put in the FAST Act. And even though that's, recent, I actually have been in the industry for well over 40 years. And we actually can go back to this issue was recognized as early as 1975, when this issue, Congress was first addressed with this issue. But the FAST Act actually made it a requirement. Okay. And so CCAM, even in 2005, made a report to the president and essentially said that standard cost allocation principles was needed if coordination was truly going to occur. And so we needed to establish cost principles and needed to work through all of this so that we could, in fact, do a better job of sharing the use of vehicles. Okay. Also, so we deal with decades, but we had issues with decades. There have always been some problems, some stumbling blocks. We are absolutely, though, at a cusp of a great thing here because a lot of things have changed in the last decade or so. There have been multiple GAO studies that have encouraged coordination of federal assistance. Also, federal agencies now have to follow the Single Audit Act. And so that basically standardized a lot of activities. There was the adoption of the Uniform Cost Principles in the administration of federal awards. Most of you will know and appreciate CFR Part 200. And so what that did is it standardized and got most federal agencies all on the same page in a number of areas. Those were instrumental in basically moving this project forward. Also, one of the things that occurred is that back years ago in the mid-'80s, Price Waterhouse actually created a two variable cost allocation model that in the last 30 years or so has become the standard, at least for FTA and public transit entities. And so there's already a standard approach to cost allocation that's been in practice for years. And that also now, automation is great, technology is great. Now most public and most private entities do have access to an automated accounting software. And so that in of itself also was instrumental in standardization, but also in providing inputs into the model. And then the biggest thing is CCAM and what they've been able to do and the relationship that FTA has been able to foster with CMS. Like I said, lots of things that have occurred. I think one of the other big things that has occurred is because Medicaid is their transportation assurance is an assurance, it's a requirement, but there's no cap to it. So because of that, the focus on cost and trying to create environments or create a situation where they can still provide the service, but at the lowest cost possible, all of a sudden now has put some more emphasis on doing cost allocation and potentially sharing cost of trips. Okay. We've had some problems, however, in doing this, in that, even though we've got CMS at the table, quite honestly, NEMT only amounts for less than 1% of the total Medicaid budget. So we're still continuing to fight a little bit with being a priority. And another interesting thing is over the last several decades, the basic service delivery model that Medicaid has been using and that many of you probably are experiencing or fall under different models, depending on what happened in your particular state at various and sundry times. But back in the early days of Medicaid NEMT service, it was essentially a fee for service at the local level. But then as states brought it up and tried to do things on the state level, then there was the big push to do brokered service, primarily private brokered services on a regional or statewide level. But now the model is essentially moving. And now what we're seeing is a significant focus on managed care at the statewide level. And so because there are these different models that are out there, sometimes it makes it difficult to try to come up with one model that can fit all of those different scenarios. And like I said, we got 50 different approaches to the way NEMT services are provided. So that in fact actually was a big challenge. And then the biggest problem was that Medicaid and CMS only don't care about vehicle trips. They care about person trips. And so there was a major philosophical difference between the way transit people look at scheduling trips versus and pricing trips and costing trips versus the way that Medicaid does. And so that was one of the biggest barriers that we had to address. And again, some of those issues that were identified in the guidance regarding deadhead miles and no-shows and those types of things, those were all issues that had to be addressed. And then also one of the issues with that we had to focus on with our model is making sure that because it has financial information in it, that the whatever cost allocation method is used, that it needs to be protected, and that there needs to, whatever platform is used needs to have the necessary security. So this model, I don't think I've made this clear, so let me make this clear. The model that we're talking about for CCAM will be deployed and available nationally. It will probably be housed on an FTA or a CCAM, it'll be hosted on a CCAM site, so that all individuals, private, public, everybody, transit agencies, nonprofit organizations, everybody will have access to the model. All the information will be maintained in the cloud. So that's why that security information is extremely important. And that the model essentially can handle and address all of these different types of service providers and the different state Medicaid models. Okay. Another problem that we have is when you look at that list, we pretty much are good to go when it comes to public transit or public entities. Where we have some snags are obviously trying to get information from the private sector, because one of the things that we are doing is having data entry validation procedures. And so part of that has become a little bit challenging. We're still working on that. But I think that part of the issue is just trying to really understand the nuanced processes and perceptions and the ways that individuals, both CMS, transit, as well as the different types of service providers look at wayfinding applications. Okay, so those were some challenges, but we've figured out most of them. So the new model, like I said, it will be ultimately hosted in the cloud by either FTA or CCAM. It is based on a uniform budget template that both CMS and FTA have agreed upon. It basically is based on the old Price Waterhouse cost allocation techniques. It includes adoption of a CMS budget certification process. In other words, CMS wants to make sure that you are certifying that the data is in fact actually correct. So we basically are mimicking that. And we had to deal with the whole issues of depreciation for private sector folks. For non-federal folks, obviously that's not an issue for those of us in the public sector. but we had to address those issues. There were some stumbling blocks there, but we got through that. And then also understanding that the model can be used to determine the full allocated cost. But once you determine the full allocated cost, then it can be used to determine various pricing structures, and can be used for individual trips or batch trips or any one of a number of different types of trips. Probably the biggest thing that came out of it was adding interactive map applications. We can actually thank our friends in the TNC world for doing this, because it really significantly helped deal with with CMS's concern about only paying the fair share of their portion of the cost. So let me use an example here to show you what I'm talking about. This is a model that is traditional transit vehicle trip scheduling. So if you can follow along, you can, and if you can see the colors here, the purple colors would represent a Medicaid client, but you're going to see that at 714, for example, first of all, they left the base, they deadheaded to the first pickup at 714, and then they dropped that person off at 735. Okay, that's straightforward. But then they picked up the next person at 753, but that Medicaid person was still on a vehicle when we, because of our efficient scheduling with transit, we then go pick up a third passenger who is a senior client, and then we pick up another client before we then drop that Medicaid passenger off at 8:45. When you look at this, this is the way in transit we schedule. We want to be efficient. We we figure out the best way, the most efficient way to get all the people picked up and to get them all dropped off, but we look at it as a trip. That's not the way CMS looks at it. CMS does not want to deviate from its route to pick up passenger 3 and passenger 4. And even though the total trip is cheaper, the concern is it really cheaper for the CMS or the Medicaid passenger? And CMS has always said, no, obviously it can't be. We're going out of our way. And so this has been a stumbling block. So this process, this graphic depicts how the formula or how the model works, and that even though the vehicle still may go the path that we just described, that's not how CMS would be charged for the trip. CMS would be charged based on the direct distance from that origin to that destination. And so the model allows, even though the vehicle may go this other pathway, the actual total costs then are going to be divvied out based on, what the direct distance would be from passenger the pickup to their drop off. So it's kind of like a Uber method of determining what the trip cost is. You might go a whole lot of other ways, but when you get on that vehicle, you get on an Uber trip, you know how much that trip's going to cost, regardless of really the way that the driver drives. And so this is pretty much the same methodology that's used in this model. And CMS has participated in this and thinks this is an appropriate way of doing cost allocation. Okay. I want to be cognizant of time, so I think I've got just a few more minutes here before we're going to open it up to questions. Just want to say that the model has migrated from the development platform to the cloud. It's currently being tested. We're trying to test it in a number of environments. Again, we've got a little bit of an issue with the testing in the private sector arena, but we're still working on that. So far the results have been pretty promising. We'll be making some modifications based on the field testing. We are incorporating a few other value added functions to it. And then we're going to be soon developing documentation manuals and user manuals on how to use it. So this is just a real quick example of what it looks like. This is where you would put in your organization's information. This is where you would indicate what kind of organization you are. Depending on what kind of organization you are, you would potentially go to different screens. If you're a private sector, yours is going to look a lot different than if you're a public sector entity. And so this depending on how you answer this, will depend on how the model works for you. Then essentially you put in your hours and miles from your previous years, because again, the two variable models based on miles and hours. This is the certification that we talked about, that CMS wanted to make sure that people were swearing that they actually that the data is correct and accurate. And then there's the opportunity to put in the financial information. There, for folks who don't have certain information, there will be default values. Again, hopefully that's, people are going to have the information they can provide in here. In public transportation, most nonprofits are not going to have a problem, but for other entities, there will either be default values. There will also be flags in here if you basically put in information that is out of range or doesn't make sense. And so what happens is all of that, this should look familiar to anybody who knows cost allocation, that basically it gets divvied out into what's expenses are allowed, what are not. And then what happens is you basically put in once that information is all in there, then for like an NEMT trip, you put in the origin, you put in the destination, and then it will use that cost allocation method to actually calculate the trip cost. There is the possibility that this can actually interface with other scheduled dispatch software. So, but what could happen here is you could actually pull this out, and this could actually be your documentation about why a certain trip would be, why you would be charging your NEMT entity, this in this case, $3.71 for this trip. So this would use this methodology. It would basically print this out. It would be what the cost is, and then you could use this for documentation to substantiate the cost of your trip. So this is just an example. This is kind of like another one. So these are kind of like what the screening outcomes would be. And like I said, the model is still in works, but we've got this working pretty well, and CMS has been demonstrated to them multiple times. Again, they haven't used the word endorsed, but they have said that we can say that they had input in this, and it does seem to represent the cost allocation methodology that would be usable by state Medicaid directors, brokers, MCOs, any entity. So that's kind of it in a nutshell. How did I do on time, Liz? I think we said to leave 15 minutes. I think I left 18. So I'm open for questions. There was a lot of information, guys. I get a lot of information. So but I'm open for any questions.
All right, sounds good. Thank you, Robbie. So first question, how does no other option available and least costly come into play when Section 5311 public transportation systems offer low fares to the general public, but are also the NEMT partners?
Okay. So typically, depending on what the model is used in your state, typically the NNT entity, whether it's a broker or an MCO, or even like a local job and family services entity, when they're aware that trips need to be provided, typically what they do using the methods that they use is they will determine, maybe they put that trip out and see who wants to take it, and then based on that, they will assign it to what they view as the lowest cost, most appropriate. Historically, my experience has been usually they make that decision based on lowest cost and perhaps not taking into consideration most appropriate. And I think that's what this guidance is challenging the states to do, is to take that into consideration first. I can't speak to, I can make suggestions and would love to make suggestions on how that could be determined. But essentially, if an individual has, specific needs, or already has a working relationship with a public transit entity. All of those things could go into the determination of most appropriate, so that instead of that broker or that entity putting it out to, maybe 3 or 4 different service providers, it may be that only 1 or 2, and maybe 1, maybe just the public transit system is really most appropriate. And then you look at most appropriate and then low cost. So I guess the assumptions have, in my opinion, previously, the assumptions have been that everybody is appropriate. And so they just deal with low cost. And I think that what I see the possibilities here is that that those entities need to determine who is most appropriate for that provider first, and then taking the low cost, after they've determined, who is appropriate. In my experience, public transportation is going to win out every time. Now that's my bias, I admit, but I do think that because of our reliability, because of our relationship with our clients, because of all those things, we absolutely are going to be most appropriate in a number of cases.
Okay.
And I just want to make sure I'm pointing out here is that what this does is gives these flexibilities to the state Medicaid directors. They don't have to do any of these things. What this is going to do is give you the opportunity to go to the table and use this guidance, use these words, use these concepts to try to make sure that public transportation is in the best place when you're having that dialogue.
Okay. There were some questions about rates. So does the new guidance help get around the restriction on paying no more than what the public pays? For example, our small urban ADA paratransit service is $4 per trip for members of the public who are certified as unable to ride the fixed route. JFS feels they don't want to pay more than $4 for any demand response service, which is obviously well below our cost.
So the question is, do you already provide service to other human service agencies? Do you provide contract services? Do you, because if you already provide your complimentary paratransit service, you're using that to provide other trips, contract trips to other agencies, then the answer is yes. If your local JFS is wanting you to provide these services, then you can charge them whatever the rate is that is the lowest of the contract rates that you're doing for other human service agencies. So that's the answer. If you, however, are not providing any of those, this still gives you the opportunity to go in and negotiate a rate with them. So they don't have to, but this gives you that opportunity. This guidance gives you the opportunity to negotiate that rate. Previously, it was thought that it was prohibited. This regulation, or this guidance specifically says that that's not prohibited. That if a local state Medicaid director, they have the flexibility to allow you to negotiate those rates for complimentary paratransit service trips. So I don't know if I've made that clear. It's just, but the caveat, so yes, you can negotiate a higher rate. They don't have to necessarily give you those trips. But if you do negotiate a higher rate, that higher rate cannot be any greater than the lowest contract rate you charge other folks.
There was another question similar to this, where if you don't have any other contracts, is that where the cost allocation and the actual costs of the trip would be you're negotiating?
Yes.
What you negotiate. Yeah.
Yes, I believe so. And remember, I kind of emphasized there was a quote there that basically said paratransit should not be, the burden of the whole transportation cost. In other words, what they're saying is okay, guys, we understand that this is very expensive. And so in those particular cases that you can negotiate. Now, it's not, they don't require them to take the price that you give them. They don't have to give you trips. And if the individual is an individual, that individual is going to be they would be treated like any other individual.
Right.
Does that make sense? So if the individual's acting as an individual, then they'll get the same fare as any other individual would. If there is an agency that is requiring services be provided, and they're not acting on behalf, they're not like doing for one individual, but they're basically negotiating this, then it's the agency, and then you can negotiate an agency rate per trip. I know that.
Okay.
Okay.
There are a couple other questions on this. I don't know if some of them have already been answered, but one is, would comparable service have more consideration than just a contract? So higher volumes and group trips for an organization not being the same as an individual medical trip?
Yes, I believe so. So as long as you're, if you just need to be consistent, if I understand the question correctly.
Right. Okay.
So you are correct. It's comparability, and that the word comparability is actually in the guidance.
All right. Is the rate to charge Medicaid the lowest that we charge other services, or that we also charge the public? I think you've already addressed this, but.
Right. It would be other human service agencies.
Okay. If you don't have any contracts due to charter rules, can a public transit agency bill Medicaid? Oh, we already kind of addressed this, the posted rate for ADA and demand response. Yeah, I think we already answered that, but. Okay. Are there successful best practice or pilot projects to operate NEMT at a regional level versus statewide brokerage programs?
There are regional systems, and again, it depends on what's going on in like your individual states. For example, the managed care organizations, they typically are regional, and they do brokerage within their own specific service areas. And so, yeah, there are a number of different folks that do states that do things on a regional basis, not just statewide.
Under
what I would say is that there is a TCRP project that was done a few years ago that addresses all the different models that were current at that time. And then TCRP is, I believe National Center for Mobility Management is actually doing a study right now that is going to come up with the most up-to-date summary of the way all the different states are performing NEMT services now. So that information will be, I think this summer is going to be released.
Great. A question about trip sharing. Does this mean that more than one Medicaid client can be transported at one time and bill for both, or bill the difference in the mileage for the trips?
It means the way the Medicaid wants to do it is they want it billed per person. So yeah, if you put 2 people on that trip, then it's point A to point B. And so it in some ways, this is an area that doesn't make sense to me and doesn't make sense to a lot of transportation professionals who are concerned about efficiency, but they want, you can put 2 Medicaid people on one vehicle, and it's the origin to the destination for A and the origin to destination, for passenger B, using the cost allocation model that process that has been that CMS has had input into.
Great. Can managed care reimbursements be used as match for 5310 and the other grants listed? And I think 5311 and 5307.
If they would be a contract. I mean, so yeah, it would be like any other contract that you would have. So it could be used for as local match.
Okay. What is the justification for matching federal state Medicaid funds with federal 5310 and 5311? Explain how Medicaid funds can be used as a match.
It's essentially, as I just said. So You know, back in the day, whenever you do a fee for service, they would, you know, contract with the local entity, or whether it's a broker or whether it's whatever. Essentially, what's happening is you're being paid with Medicaid dollars to provide trips. Those Medicaid dollars would be like contracts, and so you can use contracts as local match. So it'd be like any other contract with any other entity. If you had a contract with your local aging, you know, to basically, you know, provide trips to their a meal site or something like that, and that's a contract. For the 5311 you know, systems, and those of you who can, you know, use those designated federal monies, they can be used as match for your 5311 program. And there's a whole, if you're interested, CCAM has a whole, go to their website, a whole thing on fundraising, and I think they've looked at 134 different federal entities, and they've researched each one, and they've determined which of those funding sources can be used as local match to match 5311, 5307 funds. So I highly recommend, if you're not familiar with that, you go to CCAM's website and pull out that fundraising guide.
Great, thank you. Who do you negotiate the price of the trip with for Medicaid?
Well, it depends on what is going on in your particular state. If you are in a state that's using, you know, managed care organizations, some managed care organizations are dealing with providers directly. Most of them, however, contract out with a broker. But they will follow the direction and the guidance of the MCO on how that is to occur. But the broker would actually be the entity that the provider would negotiate with. If it's a state that has a statewide broker or a regional broker, then the negotiation occurs with whatever that broker is. If you're in a state that does where Medicaid monies are going through local you know, governmental entities or departments, then whoever that is who you would negotiate with. So it really does depend on what's happening in your specific state and in your specific area, and who's involved. So you really need to do some significant research in what's going on in your local state in order to be able to, you know, ask the right questions and know who to talk to.
Thank you. All right, we're going to take a couple more and then we'll wrap up, and we will try to go through the other questions and see if we can answer them in another way or post them. Okay, contracted providers of federally funded municipal shared ride taxi services have indicated the requirements to be a federally funded public transit provider and to an NEMT trip provider are generally overly burdensome and duplicative for things like driver training, background checks, drug testing, etc. As a result, providers are discouraged from working with the state NEMT broker to provide NEMT trips. In what ways does the new guidance help to unify requirements for providing public transit with those to provide NEMT trips?
Great question. So first of all, the guidance does not require anything, but I do think, but the point that you're bringing up is very significant. And I think that it goes back to that statement where I said state Medicaid, where the guidance encourages state Medicaid directors to work with their local state DOTs to work together to resolve some of these issues. And in many ways, that's probably where that is going to be. I'll just point out some efforts that are going on in the state of Ohio. They basically have been working for years to come up with one set of standards that all social service agencies can agree to, and also training requirements and all of those other things. So I think that we need to keep your eye on what's happening in Ohio. Does this guidance do much to further that? It sure, in my opinion, there's a lot of things in there that encourage state Medicaid directors to do a better job. and to work with state DOTs in order to help address some of those issues. If you have the ability to influence that, this would be a major area to try to get all of your state agencies together in one room and to bring those issues up. And hopefully we're going to have some real good examples here soon to show and to hopefully educate and inform other states.
Okay. Okay. One last one. Yeah, is maybe more just voicing their frustration, but who is holding brokers accountable with states contract with? We hear a lot of stories from our customers about private companies with their vehicles not being clean or trustworthy, erratic driving, and making them wait after their appointments for hours. They say they make complaints, but it falls on deaf ears.
Also, a good comment, and one that is very commonly expressed and heard. I think CMS has heard those exact same concerns, and that's why I think that when you read the guidance, that there are a number of areas where CMS has attempted to address that by stating very clearly what state Medicaid directors, what their obligations are, what they're required to do, and what the expectation is. CMS, however, stops short of dictating what that looks like. And so even though it told the state Medicaid directors, this is what you need to do, you need to be concerned about most appropriate. You need to be concerned about, are you paying such a low cost that you don't have good service providers? Are you, you need to make sure that, the service is of quality. All of those things that you mentioned are addressed within the guidance. And state Medicaid directors through this guidance are challenged to come up with a better method of improving their services. But ultimately, it falls on the shoulders of the state Medicaid directors. Again, this guidance is not requirements; it's guidance. But state Medicaid directors are the ones who have to take this guidance, seriously, and have to then look at their programs and put the necessary improvements in place, whether it's a broker or MCOs or whatever it is. It very clearly says you have to provide oversight, robust oversight of your brokers, and you have to monitor complaints, and you have to make sure that, the beneficiaries do have access to transportation. So it very clearly says these are the responsibilities that state Medicaid directors have for brokers. But it's up to the state Medicaid directors to actually then implement things in place that are consistent, that meet those, meets that guidance. I know that's perhaps not the answer that you wanted to hear, but I think that the guidance is at least, and I guess I'd like to end on this. This is not what we would have liked to have had. We would have loved to, I think, as an industry, loved to have had significant requirements, and we would love to have had all of these things that address all of these issues. But that didn't happen, nor is it likely that it would or will happen. But at the same time, this guidance is significantly more and better than anything that we've ever had before. And it does verbalize and defines and recognizes many of the issues that public transit has had over the years. It does recognize all of them. And it does encourage and spell them out and suggest to state Medicaid directors what it is that they need to do. So even though it might not have gone as far as we would have liked for it to have gone, we absolutely still have something that is well articulated, that is, been published, that we all have access to, that we all can use to help substantiate, our local community, activities, negotiations, and at the state level, it can help that dialogue at the state level. So we're better than we were. And I think that the other really positive thing about this is that CCAM continues to make significant progress with and enhancing the relationship between FTA and CMS. And I think that there are still going to be significant benefits that are going to come through that process. I would just like for us to focus not on what it doesn't say, but instead, hopefully, as an industry, we can focus on what it does say, and that hopefully it will help us be in a better position to positively, change the relationship between NEMT, public transportation, and our local communities for the future. So that's what I think I'd like to end with. Liz?
Actually, want to just ask one final thing. Do you have an estimated time frame for when the cost allocation calculator will be released?
Significant improvements are happening yet through the second quarter of this year. I think that the release is going to be based on when FTA determines exactly where it's going to be hosted. And how it's going to be managed. They're working on that. So I just would say that stay tuned. Hopefully, I probably won't be, this it's not going to be the summer, but maybe the fall. But don't hold me to that. Again, it's going to be on where FTA chooses to house it and host it.
Super. Thank you. Thank you so much, Robbie. Well, I understand we're a few minutes over, and we really appreciate your time, Robbie, and all of you for joining us today. We do have some additional events that I just want to make sure you are aware of before we close. We have a 2.5-day capital projects training in Spokane, Washington in April, so registration is open for that. We're hosting a few TSI trainings. That's the Transportation Safety Institute. And you can register through TSI. The one coming up next month flows through TSI, but we could maybe, I think, have a registration on our own, so let us know if you're interested. We have a new active shooter training and are going to be doing a webinar on April 2nd about kind of an overview of that and how to utilize the materials in that course. FTA is going to be presenting an early property acquisition and NEPA compliance webinar on April 25th. And there are a bunch of other events by FTA, NTI, and others on bus procurement, NTD reporting, GIS tools, public involvement, and the FTA bus and low-no grants coming up. So a lot of webinars, but good opportunities for getting information that you need. And I also want to make sure everyone's aware of the other technical assistance centers that FTA supports. And the National Center for Mobility Management has been mentioned today, but also the National Aging and Disability Transportation Center, the National Center on Applied Transit Technology, the Shared Use Mobility Center, and the Transit Workforce Center. And they all provide different trainings and technical assistance and materials, as well as many of them offer grant programs. So check them out. And we all work together on the Transportation Technical Assistance Coordination Library, or TACL, and that hosts a lot of transportation coordination resources that may be of particular interest with this audience. So check that out. And all the links to these partners and our webinars and things are on our website. And if you have trouble finding anything or have a question, please let us know. So thank you again so much, Robbie. Thank you everyone for joining us, and we will get all the slides, including the ones that you couldn't see at the beginning, which were not as important, but those will all be on our website by the end of the week, along with the recording, and we'll stay tuned for additional training opportunities on this topic. And thank you so much. Have a great rest of your week.